This is a case of nuclear 3 cataract in a 69 years old lady suffers of cornea guttata. As you can see, there is a sort of beaten metal appearance on the back surface of the cornea, denoting marked cornea guttata. Here, specular microscopy showed marked polymegatism and pleomorphism, and her endothelial cell count was less than 1,000 cells per square millimeter. As you can see, there is a faint ring delineating the nucleus, denoting hard cataract, despite good reflex on the surgical microscope. In these cases in particular, we have to employ every tool to protect the corneal endothelium. So I started by employing the soft shell technique by injection of dispersive and cohesive OVD to protect the corneal endothelium during rhexis formation and throughout the phacoemulsification procedure. This lady is a single-eyed patient. She lost her other eye by phacoemulsification done elsewhere, and because of the corneal decompensation, now she is scheduled for the MIC surgery in the other eye. We can re-inject every now and then OVD to refill the anterior chamber during rhexis formation and to control the direction of the tear of the capsular flap during rhexis formation. So after finishing the rhexis, we can now do the hydrodissection, and before phacoemulsification, I'm trying here to disassemble the nucleus mechanically before starting phacoemulsification. Injection of dispersive OVD for further protection of the corneal endothelium, and this is the MiLOOP device of Zeiss. This is the microfilament device made of nitinol, and this filament can be advanced between the lens nucleus and the lens capsule and swipe to cross the lens equator to the posterior pole of the lens, and we can retract the filament. We can divide here the nucleus into two halves. It's very important to support the nucleus by the second instrument because sometimes the nucleus tends to evert in the vertical direction caused by retraction of the nitinol filament. We can divide the nucleus into two halves, and we can repeat the process if we further want to divide the nucleus into 4 quadrants. So I under-rotate the nucleus and now advance the MiLOOP filament between the lens nucleus and the lens capsule, and by retraction of this loop again, we can divide the nucleus into 4 quadrants or at least 3 fragments inside the capsular bag. Now, before starting phacoemulsification, injection of dispersive OVD for further protection of the corneal endothelium, and now phacoemulsification starts by aspiration of some of the cortex in front of the lens nucleus, and as you can see here, the lens nucleus has been divided at least into 3 quadrants without any ultrasound energy inside the anterior chamber. So this device has tremendous effect in minimizing the ultrasound energy consumption inside the eye and protection of the corneal endothelium in such cases. As you can see again, I'm keeping the phaco tip directed downwards to further reduce the ultrasound dispersion against the corneal endothelium. Of course, this might jeopardize the posterior capsule. However, the fluidic settings here in these cases play a major role in stability of the anterior chamber during phacoemulsification. As you can see here with the second instrument, I'm trying to mechanically smash those fragments against the phaco tip to reduce the ultrasound energy consumption inside the eye. So every measurement can be employed to minimize the ultrasound energy inside the eye and protect the corneal endothelium. Again, with the second instrument, we can further divide those fragments into smaller pieces and smash those fragments against the phaco tip. Again, as you can see, I'm keeping the bevel down to reduce the ultrasound dispersion against the endothelium. This is the last piece. Now we are left with the small epinucleus Of course, the fluidics, as I mentioned before, plays a major role in keeping the stability of the anterior chamber throughout the phacoemulsification procedure. Now we have done with the phacoemulsification part of the surgery and we are ready for irrigation aspiration. I found that the anterior chamber is very shallow. I usually tend not to do a second paracentesis, but in this case, in further to reduce the tension inside the eye, it's better to reduce the tension of the speculum on the eye. And you can see here the tension has been eased down, denoted by the corrugation of the cornea. And after filling the anterior chamber with OVD, I did another paracentesis and continued irrigation aspiration for cortical cleanup in the usual way. And finally, implantation of the single piece IOL inside the capsular bag. And after implantation, it's very important to try to remove all the viscoelastic from above and from underneath the IOL. Presence of viscoelastic inside the anterior chamber and inside the capsular bag underneath the IOL will induce pressure spikes in the first few days after the surgery. So, in order not to jeopardize this weakened corneal endothelium, we have to minimize the possibility of pressure spikes in the first few days after the surgery by trying to clean most of the viscoelastics from the anterior chamber. It's quite difficult to remove the dispersive OVD from the back surface of the cornea. As you can see, I left some of uh, the dispersive OVD on the back surface of the cornea because trying to remove those viscoelastic parts may jeopardize mechanically the corneal endothelium. So it's better to remove as much as we can, but the dispersive OVD on the back surface of the cornea, it's quite difficult to be removed, so it's better to be left inside the eye. Thank you very much for your attention.